of sunscreen to reduce your risk of melanoma. When it comes to the risk of flying, skin cancer may not be the first hazard, but this report that was in JAMA Dermatology said that pilots are 2.2 times, means twice as likely to have melanoma than the general population, and the flight attendants in the cabin are 2 times more likely, and in captains, pilots, it's more likely to be fatal. Now, there's about 76,000 Americans with melanoma, and about 9,000 will die of the melanoma. So it's a serious health concern, and the rates of melanoma have been going up tremendously. Probably has to do with leisure time and sun exposure. There's been dozens of studies that have looked at melanoma. Now, flight crews get cosmic rays, they get ultraviolet rays. Workers from the University of California, San Francisco looked through 266,000 participants. They found that pilots and flight attendants had increased rates of melanoma, but only the pilots had an increased death rate. The mortality was 83% higher, so about double the rate of the general population. So it's probably not the cosmic rays, it's probably not UVB, but probably UVA that can penetrate glass, and the higher the plane flies, the more UVA radiation there is, especially above the clouds or snow-covered mountains. They get more UVA reflected from below. So it's a warning that even in the plane, even traveling, you are not immune from UVA and the risk of skin cancer. So cover up, put on your hat, long sleeves, pants, sunscreen, even if you're going to the grocery store. Let's help decrease skin cancer, aging of the skin, decrease melanoma, and decrease death. We have a caller. Good evening.
Yes, how you doing, Doc? How's everything?
I'm fine. How are you?
All right, very good. Yeah, I'm calling in regards to chemotherapy and radiation.
Okay.
My mother had cancer. She's now deceased.
I'm sorry to hear that.
First bout was in 1978.
Why don't you tell me your question? Why don't you tell me your question? That's what I'd like to hear, please.
Do you feel that any time that prior to surgery with chemo and radiation, when they open the body up to then remove the cancer, do you think it's like the air setting fire? Because I'm just wondering, because my mother had that issue where they said they removed all the cancer. However, there were cells available. There were still cells there, and they put her on a medication, and she had a tumor grow back within 6 weeks, and she succumbed to that.
And what's your question?
Do you think chemo and radiation have before surgery given, and then surgery is performed? Do you think increases the chances of cancer recurring?
No, in fact, just the opposite. There's lots of examples to quote to you. For example, rectal cancer, cancer of the rectum, used to be treated with surgery first, and then depending on the pathologic findings, if it was through the wall of the rectum or involved the lymph nodes, which would be stage 2 or stage 3, only then did people get chemo and radiation. And now the philosophy is exactly the opposite, to try to give the chemo and the radiation first for rectal cancer, to decrease the size of the rectal cancer so that a smaller operation can be performed, and the person is more likely to keep their anus. If the surgeon removes the anus, it means you have to have a colostomy bag. If we can decrease the size of the cancer with chemo and radiation first, it means you can keep your anus and you can control your bowels and no colostomy. So the answer to your question is, in certain cases, let's say every patient is different and there's not one answer for everybody, but in many cases, chemo and radiation can be used in advance and used safely.
Okay, because the only reason why I asked is the 3 cancers she had was the same exact cancer. And the 2 surgeries she had, she did not require any chemo or radiation. The third one, she got the chemo and radiation, and then 6 weeks later she was deceased. So
right. Well, it would suggest that the cancer was already percolating pretty aggressively, unless, of course, she died from something else like anesthesia. And, of course, this week our hearts go out to Joan Rivers' family, who had this procedure and apparently succumbed during the procedure and possibly from anesthesia, although I'm not involved with the case. I know no details, but apparently she was performing the night before, and the next day she's rushed unconscious in heart arrest to a hospital. So there are dangers with surgery. I'm not saying it's not. Our goal is obviously to treat people as much as we can outpatient, without surgery, non-invasive radiosurgery, which is pinpoint treatment. It says radiosurgery, but it's not surgery. It's pinpoint, non-invasive treatment. One of our patients likes to say it's radio zapping to hit the cancer without the surgery. So if you don't like the surgery, give us a call. Even if you like the surgery, give us a call. You might learn something. You might learn about new choices. And by the way, that's why our phone number is 212-CHOICES. Thank you for calling, and have a great weekend.
Thank you. You too, sir. Thank you.
Okay. God bless you, and bye-bye now. I want to talk about a couple other patients. Another skin cancer, actually, is on my list today. But an Irishman, and Irish have more fair complexion, and who knows what it's from. Maybe it's from being up north where there isn't much sun, but Irish people do have fair skin, often blue eyes, and fair skin are more prone to burning and sun damage of the skin. This man was of Irish heritage, and he had 4 skin cancers, all basal cells. He came to us for treatment this spring. We treated all 4. He came to me this week. He's in complete remission. He saw others. He actually saw surgeons like this caller just talked about. He saw surgeons who wanted to do Mohs, M-O-H-S, Mohs surgery, which is kind of like slicing a salami. This man had 4 cancers of the face. So you can imagine if they did the salami slicing on his face, what he'd look like. He did not want to have that. One was by his eye, especially. So he had treatment. He's in remission, doing well, and he's very happy. Me too. I'm equally happy for him. I'm very happy for him. And we had another woman talking about rectal cancer. So this is a woman that came to us. She's about 75 years old. She had biopsy-proven breast cancer elsewhere. Now, she had some anemia, but elsewhere they didn't stage her up. They're just going to do their cutting and things. They were ready to cut without staging her. And I like to stage the person, or at least I like to suggest to the patient. The patient gets to decide everything, but I think it makes sense. I think most people understand it makes a lot of sense. If you know where the cancer is, then you can give better treatment. So she came in with a breast cancer. We staged her up, and she came in Thursday, staged her up, and guess what? We found a rectal cancer, totally unrelated to the breast cancer. So she has 2 cancers, and they're 2 highly likely curable cancers. Now, she was going to a big hospital, and she was anemic, and yet they didn't look for the cause of the anemia. They didn't stage her up, so she came to Radiosurgery in New York. One day, she had the answers, she had the options, she had the choices, and now